streaming.
I remember my mom always telling me, don't ask, don't tell, in regards to illness. For my Chinese family, being sick is a taboo, so we never talked about it. When I became pregnant with my first child, I find out I have hepatitis B. I was very shocked. Only then did I learn from my mom that she also has chronic hepatitis B virus, and that I probably got it from her. I know the transmission wasn't her fault, and yet I wish she had told me sooner. I decided I wanted to do motherhood differently. I was blessed because my OBGYN knew what to screen for and took precautions to prevent transmission from mother to child. My 2 children got vaccines at birth and then completed the 3 shots afterward. When they were retested at age 1 and again at age 2, the test came back negative. But my doctor told me that because I have chronic hepatitis B, I have a 25% chance of getting liver cancer. Will I be able to see my children grow up to adulthood? Will I have to leave them too early? I chose to be very open with my children about the virus, and I started reaching out to Asian communities too. When my children attended Chinese language school, I set up a hepatitis education booth for parents. My children manned the booth with me and talked to their friends about vaccination. Later, when they left home for university, they continued doing hepatitis B outreach on their own. I did too. I remember my son coming home during a school break and saying, "Hepatitis B is a silent killer. Testing is so important, and vaccination can prevent the infection." I told him, "You got it. I am so proud of you." I used it to think my passion for preventing hepatitis B would live in me until I die. Now, I think it will live longer than that. Just be grateful.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
집에 왔는데 와이프가 저녁을 차리면서 진단 잘 받고 왔어? 근데 한마디로 나 간암이래. 전부 그 침묵이 흘렀죠. 그 마누라가 와이프가 여보 내 간 줄게. 많이 울었죠. 안녕하세요. 저는 민경윤입니다. 현재 65세이고 여태까지 그 한 직장에서 35년 동안 근무하고 은퇴한 지 한 7, 8년 되고 있습니다. 육남매 중에서 오남매가 수직 감염이 됐습니다. 그래서 제가 막내인데 두 형님들은 그때 당시만 해도 치료약이 없었기 때문에 간경변으로 해가지고 50대 초반에 돌아가셨고 어머니는 59에 돌아가셨습니다. 그래서 결국에 또 59세에 또 간암 발병을 했죠. 저도. 그래서 이런 그 비형 간암의 그 집안 내력이라는 게 상당히 좀 뭐라 그럴까 어떻게 보면 무서운 거죠. 그 환우들 모임이 있더라고요. 그래서 그 모임에 들어가서 이렇게 좀 제가 알고 있는 지식을 가지고 답글을 써주다가 직접 운영하는 카페도 운영해가지고 그 환우들이 몇만 명씩 지금 들어와서 제가 쓴 글을 보고 공부하고 제 치료 경험을 토대로 해가지고 답글을 써주고 또 병원까지 안내하고.
간염 보유자들은 자기를 드러내지 않고 굉장히 감추려는 그 본능적인 방어가 심합니다. 이 사람은 굉장히 모범적인 간암 환자로 많은 사람들한테 등불이 되어주려고 노력을 하고 있으니까 그 책임감만으로도 이 사람은 앞으로 굉장히 건강을 잘 유지하고 천수를 누리겠다라는 저는 아주 굳은 믿음을 갖고 있습니다.
또 치료도 잘 됐다고 하는 그런 걸 들을 때마다 많이 좀 어떤 성취감도 느끼고 보람도 느끼고 있습니다. 솔직히 그 만성 비형 간염 질환은 누군가에게 큰 부담을 주지만 또 정기검진을 안 받고 조치를 취하지 않은 대가는 훨씬 크다고 생각합니다. 젊은 세대와 우리 같은 기성세대 친구들과 지속적인 그 협력 속에서 온라인에서 커뮤니티를 구축하여 우리 그 비형 간염 보유자들에게 지속적인 도움을 주고 싶습니다. 정말로 두려움 때문에 여러분의 건강을 돌보기 위한 노력이 지연되지 않도록 하시길 바랍니다. 자신의 상태를 아는 것이 자신의 생명을 구하는 지름길입니다.
Hello, welcome to everybody to the session entitled Hepatitis and Liver Cancer, Gaps and Opportunities. My name is Maria Buti. I am Professor of Medicine at Hospital Universitario Vallebron and currently the Chair of Public Health and Policy at ISE. I would like to introduce my co-chair, Professor Jamal Shisha, from the Egyptian Liver Research Institute and Hospital in Cairo. Let's start with the first speaker. It's Ibrahim Yege from Safara Hepatitis, Senegal, and he's going to talk about his personal story.
Being told when you are diagnosed that you have a chronic disease such as chronic hepatitis B generate legitimate concern in the patient. I am in a good position to talk about this myself, being a chronic carrier of HBV followed by a co-infection with the Delta virus. Good day to all. My name is Ibrahim Gueye from Senegal. Born in 1964, I was nicknamed the malaria patient at a very young age, and my parents often called on a traditional healer who excelled in the treatment of yellow fever to treat my illness. However, the problem was never solved. I was in ignorance, and my health ended up deteriorating over time to the fact that I was diagnosed late. It was only in 2010 that I knew the real cause of my suffering. Following a long illness, I was diagnosed with hepatitis B. The paraclinical examination that followed confirmed that I was indeed suffering from active chronic hepatitis B. In 2011, a third liver test revealed a co-infection with HDV, and this was the summum of the challenge, as I had to face a very rigorous follow-up with more frequent tests and very expensive treatment. I was physically, morally, and financially devastated. From 2011 to 2015, I was exhausted by repeated checkup and examination, blood test, ultrasound, scanner, fibroscan, viral load. I was exhausted by a treatment with side effects interferon for 48 weeks, renewed 3 times. I was suffocating from 2 loans taken out from my employer and the bank, in addition to the sale of my house and personal vehicle to cover my medical expenses. I was a victim of stigmatization in the workplace place. After a few years of follow-up, treatments, and assessment, I was finally diagnosed with cancer, which required chemioembolization in 2016. This stopped the cancer for progressing. Then in December 2021, I was able to benefit from a liver transplant in Egypt, following a liver organ donation from my eldest daughter, Ngonege. May Allah bless her. Amen. This operation was expensive, as it has to include the cost of transplant, medical expenses, and all the expenses such as transportation, accommodation, and stay for 3 people, patient, donor, and accompanying person. After the liver transplant, which was very successful, I am no longer a carrier of HPS, G, and HDV, and my cancer is cured now. Therefore, I consider that fighting for oneself and for others who are victims of the same pathology allows one to overcome his own suffering, his own illness, and to fully assume his own destiny. I was able to overcome my fear, to take charge of my disease by creating an association, Suffering Hepatitis, to fight effectively against this infection, which changed the life of thousands of people a day. Informing people about the disease, which can easily be prevented by vaccination, about existing treatments that give good result if the diagnosis is not made too late, about progress in research, particularly in the therapeutic field, guiding patients in their medical and social pathways, listening to and answering the question of patients and their family. These are the key issues in my involvement in the association that have made me founding president of Suffer Hepatitis, honorary president of Suffer Hepatitis, member of the board of director of ALPA and AFHE, member of WHE. Many thanks to all the people who have accompanied me in this fight, and particularly to my daughter, Ngone, life donor, to my family, to Professor Moussa Seydi and Pape Saliou Mbaye from Senegal, to Professor Gamal Sheha and Abdou Wahab from Egypt. Thanks also to Dr. Lucy from WHO and all the members of WHA. Thanks finally to the Minister of Health and Social Action, Abdoulaye Diouf Sarr, to the Minister, Cheikh Tidiane Gadio, and to the President of Senegal, His Excellency Macky Sall.
So thank you very much. I think there is a problem with the audio of Professor Gamal.
Yes,
Okay. Do you like to introduce the next speaker, please?
yes. I have the pleasure and honor to introduce the next speaker, Professor Louis Roberts from Mayo Clinic. His talk is about hepatitis and liver cancer control, the urgency of implementing what we know. Please, Professor Louis.
Greetings. I would like to thank the organizers of the World Hepatitis Summit for the opportunity to present at this meeting. So liver cancer is the most lethal of the major cancers. This shows data from IARC that shows that in terms of the number of cases of cancer each year, liver is the number 6 most common cause of cancer in terms of incidence, but in terms of mortality, it falls number 2 after lung cancer and has the highest mortality ratio, with 92% of people who are diagnosed with liver cancer dying within 1 year of diagnosis. There's a high rate of liver cancer deaths, particularly in Africa and Asia. And it's important to put these liver cancer deaths into context. If we think about the number of people who died in the West African Ebola epidemic between 2014 and 2016, there were 11,300. But this caused a major global response because of concerns about transmission. If we think about the number of children who were affected by the congenital Zika syndrome between 2015 and 2018, there were 3,300 in Brazil alone. But once again, this caused a major global response due to concerns about transmission about the Zika syndrome. So we have about 800,000 deaths per year, which something is an underestimate, from liver cancer. That is 2,200 deaths a day, or 1.5 deaths per minute. Does this not qualify as an epidemic simply because it is routine? So Dr. Sonia Rasmussen spoke recently at the Translational Science meeting about lessons learned from the Ebola and Zika epidemics. 3 things she mentioned. Preparedness is critical. Action is needed despite the lack of perfect evidence, and effective communications are essential. So what puzzled observers wish to know is, why do we have such a disproportionately muted global response to viral hepatitis and liver cancer deaths? As one of my colleagues in Africa said, people get sick, they dwindle, they die, even very young people. So what are the most pressing questions we need to answer? And what are the most pressing interventions that we need to implement? What do we know already about viral hepatitis treatment and liver cancer control? We know that treating viral hepatitis B and C reduces the incidence of liver cancer. We know that people with chronic hepatitis B in sub-Saharan Africa become hepatitis B E antibody positive by their teenage years. Many of them do not meet current criteria for treatment of chronic hepatitis B, which are a minimum viral load of 2,000 international units per mil. And we know that many people with chronic hepatitis B in sub-Saharan Africa will develop liver cancer between the ages of 20 to 60, with a median of between 40 and 45 years of age. And indeed, many people with chronic hepatitis B in sub-Saharan Africa will have low viral loads at the time of liver cancer diagnosis. This is data from a study we did of about 1,500 patients with hepatocellular carcinoma in sub-Saharan Africa. We see that for those with hepatitis B virus-induced cancer, the peak age was between 35 and 40 years of age. For those with HCV, the peak age is between 50 and 60 years of age. So what we know about surveillance and liver cancer control. Surveillance for liver cancer results in diagnosis of earlier stage disease. Viral hepatitis treatment improves the performance of the common screening test alpha-fetoprotein in screening. And we know that there are new blood biomarker tests and models that are equal to or better than ultrasound and alpha-fetoprotein in early detection of liver cancer. Early stage liver cancer has been shown to be more easily cured than late stage liver cancer. And treating early stage liver cancer is much more feasible and less expensive than treating late stage liver cancer. If we look at this data, for example, of a number of studies combined, we can see that the outcomes of liver cancer in Africa are abysmal. If we look here, these are the outcomes of individuals seen with liver cancer at hospitals in Taiwan and Japan. We see that the 5-year survival in Taiwan is about 70%. The 5-year survival in Japan is about 50%. Both of these regions and countries have national screening strategies for people who are at risk for liver cancer. So they detect these cancers, more than 70% of the cancers at the very early or early stage. Over here, we see the survival with liver cancer in Egypt of about 11 months. Egypt, of course, has done within Africa the most aggressive effort to detect and treat liver cancer, and due to the epidemic of hepatitis C virus. If we look at the rest of sub-Saharan Africa, in all of these other countries combined, the median survival was only 3 months. So surveillance for early cancer can make a huge difference. And we see here the surveillance gap between where there's active surveillance of all individuals at risk to where there is almost no surveillance. But there is hope. This is a tertiary medical center study that we did in Ghana, where at 3 medical centers, we started hepatitis clinics. And of the about 150 patients with hepatocellular carcinoma that were enrolled, we were able to stage 80 of these patients. And you can see in the context of these hepatitis clinics, 30% of the patients that were diagnosed with liver cancer had very early or intermediate stage disease, stages that are eminently treatable. That cost is a barrier to HPV and HCC care in Africa. And we have heard about that in the patient story from Mr. Ibrahim. And we see that here in our study, that those with the lowest incomes were much less likely to be able to afford an alpha-fetoprotein test or an HPV DNA test. So what are the most important things we don't know about viral hepatitis and liver cancer control? One question is, would we reduce liver cancer deaths in sub-Saharan Africa if we treated people with chronic hepatitis B virus at a lower viral load? For example, at 200 international units per mil rather than 2,000. Secondly, would we reduce liver cancer deaths in sub-Saharan Africa if we treated all people with chronic HBV, everyone who is HB surface antigen positive? And finally, would we reduce liver cancer deaths in sub-Saharan Africa if we treated children who have chronic HBV infection? Important questions, important if we are going to address the burden of liver cancer in this large cohort of individuals who are currently positive for hepatitis B. So action is needed despite lacking perfect evidence. The purists will say that all the evidence isn't in yet, and they are right. But this is public health, and we need to act. And the cost of inaction includes the cumulative burden of preventable deaths while we are making up our minds. Sir Austin Bradford Hill said, all scientific work is incomplete, whether it be observational or experimental. All scientific work is liable to be upset or modified by advancing knowledge. But that does not confer upon us a freedom to ignore the knowledge we already have or to postpone the action that it appears to demand at a given time. Finally, effective communications are essential. Communications between healthcare personnel and communications between healthcare and the public, as well as the importance of listening to the public and advocacy organizations and social organizations. So a few final comments, and these are from Dr. Michael Ryan at WHO. The virus will always get you if you don't move quickly. If you need to be right before you move, you will never win. Perfection is the enemy of the good when it comes to emergency management, and community engagement is incredibly important. And finally, the problem in society we have at the moment is everyone is afraid of making a mistake. Everyone is afraid of the consequence of error. But the greatest error is not to move. The greatest error is to be paralyzed by the fear of failure. Thank you.
Thank you. Thank you very much for the excellent presentation. And thank you for making the point of the importance of surveillance for liver cancer. The next presentation will be done by Luciana Holt. She works in the Oncoguia Cancer Organization in Brazil, and she's going to talk on viral hepatitis and liver cancer awareness month. Thank you, Luciana, for being here today.
Hello, my name is Luciana Holtz. I'm the president and founder of Oncoguia, a cancer patient advocacy organization in Brazil. I'm very happy to be here with you today to share our perspectives from Brazil about liver cancer. Oncoguia is an NGO that helps, informs, and defends of the rights of cancer patients. We do this through projects and initiatives that focus on quality information, health education, support service, and advocacy. We are proud members of the International Liver Cancer Network. We work together to improve outcomes for liver cancer. Now let's talk about liver cancer data from Brazil. Let's let you know about our reality. In 2020, liver cancer was the 10th most commonly diagnosed cancer among men and women in Brazil, with an estimated 12,000 new cases. It is the 7th most common cause of cancer-related death. Liver cancer is more common among men. Unfortunately, we are talking about a silent disease. It is difficult to diagnose early because the symptoms usually appear at a later stage. As a result, when liver cancer is diagnosed, it is already advanced and effective treatments are limited. In 2017, we participated in a multi-stakeholder group and developed a white paper about barriers to diagnosis and treatment of liver cancer in Brazil in our Brazilian health public system. The most important result of this white paper included shocking information about 62% of patients with advanced metastatic stage at the moment of the diagnosis. I'm talking about a study with more than 5,000 patients diagnosed with liver cancer. So there are many challenges to diagnosis in Brazil within SUS, our public system. It is very difficult to identify and diagnose risk factors at the primary care level. It is difficult to screen people with risk factors, such as cirrhosis, within the public health clinics, and there are often delays to schedule exams. There's also a lack of awareness about the disease, and there is a lack of infrastructure and equipment to diagnose liver cancer quickly. Finally, once diagnosed, there are limited treatments available. It is difficult to treat and manage these patients with higher complexity of care needs. Assessing treatments is difficult and becomes even more a challenge when the patient is diagnosed with cancer at an advanced stage, which requires more complex treatment protocols. So, what can be done? We must open the lines of communications to decrease the stigma and prejudices related to liver cancer and emphasize the importance of early diagnosis. We need to guarantee access to diagnostic exams for all patients living with risk factors and integrated care services for all liver cancer patients. We need to develop information systems that track health system user. And we must focus on capacity building of providers at all levels of care to identify patients who should be monitored to facilitate earlier interventions or diagnosis. A lot to do. We at Oncoguia will continue to work to support patients living with liver cancer in Brazil. Please feel free to connect with us and join in our work. Thank you for your time and attention. I look forward to further discussions.
Thank you. And now we move to the next speaker, Dr. Eleonora Filetto from the University of Sydney and Cancer Council, Australia. The talk is about liver cancer, viral hepatitis, and other major risk factors, a review of the Western Pacific region. Please, Dr. Eleonora.
My name is Eleonora Filetto, a Senior Research Fellow at the Daffodil Centre, a joint venture between the University of Sydney and Cancer Council New South Wales. I will be presenting our recent work exploring liver cancer and its risk factors in the Western Pacific region. The review was conducted in 2021 and was commissioned by the World Health Organization Western Pacific Regional Office. As we've heard throughout this conference, viral hepatitis is an important global issue and steps are being taken to address this global health concern. Given the association with liver cancer and the lag time between hepatitis infection and liver cancer development, it is important to acknowledge rising concerns around the liver cancer burden, especially in the Western Pacific region. Liver cancer is the sixth most common cancer globally, with more than 900,000 new cancer cases diagnosed in 2020. It has a poor prognosis and it's often diagnosed late which contributes to its place as the third most common cause of death. There are two main types of liver cancer, the most common of which is hepatocellular carcinoma, HCC, and intrahepatic cholangiocarcinoma. Our understanding of liver cancer in general and its risk factors is based on data available for HCC, and that will be the focus for today's presentation. Here we can see the incidence of liver cancer by country across the globe. The dark blue indicates a higher incidence, and we can see a concentration of blue in the Western Pacific region. The Western Pacific region has the highest incidence of liver cancer of all the WHO regions. For mortality, the picture is largely similar due to the poor prognosis, and the Western Pacific region has the highest mortality rate of all the WHO regions. When broken down by country, we can see that the highest burden is broadly in developing countries, where there has been higher historical viral hepatitis infection rates and low rates of testing and treatment, leading to undiagnosed or late diagnosis of infections that could lead to cancer. While there's a lower burden in developed countries, non-viral risk factors and liver disease are fast becoming prominent causes of liver cancer. It is important to understand the progression from liver disease to cancer to understand how this influences the current and future burden. The progression to liver cancer generally begins with chronic liver injury, which may eventually progress to cirrhosis, as depicted in this image. The risk of developing HCC is influenced by the underlying etiology or cause of liver disease and its treatment, the severity of liver disease, as well as individual lifestyle and environmental factors. The primary risk factor for liver cancer is cirrhosis, found in more than 80% of those diagnosed with HCC. Other major risk factors include infections, especially viral hepatitis, excessive alcohol consumption and tobacco consumption, and excess body fat and the metabolic syndrome, which is a group of conditions that can encompass diabetes. Of these, viral hepatitis infection is considered the main cause of liver disease and cancer in the region. It has been estimated that 35% of the global total of people living with hepatitis B or C reside in the Western Pacific region. These images represent the prevalence across the region and largely align with the incidence and mortality rate patterns, in that areas of higher prevalence also have higher burden of liver cancer. The impact on HCC has been directly quantified in relation to hepatitis infection. In 2018, 290,000 new HCC cases were attributed to hepatitis B and 45,000 new cancer cases were attributed to hepatitis C. By 2030, it has been estimated that these numbers will increase to approximately 480,000 new hepatitis B-related HCC cases and 59,000 new hepatitis C-related HCC cases. Interventions such as hepatitis B vaccination have been a clear priority and contributed to reducing new infections. The incidence of new infections is declining, but the burden of liver cancer will continue to rise as chronic infections remain undiagnosed and untreated. In addition to hepatitis, non-viral risk factors and interventions to address these can also contribute to control efforts. Excess body fatness and metabolic syndrome can lead to metabolic-associated fatty liver disease, which was previously referred to as non-alcoholic fatty liver disease, but the definition has more recently been broadened. The global prevalence of MAFLD has been estimated to be 50% in overweight and obese adults. Alcohol is consumed by more than half of the population aged 15 or over in the region, and consumption is reportedly increasing. The burden of the resulting alcohol-related liver disease is also predicted to increase. Tobacco consumption is currently around 26% regionally and has declined over the years. However, the chemicals from smoking can still increase the risk of HCC through liver inflammation that can promote progression to fibrosis. The 2017 Global Burden of Disease study estimated that almost 8% of liver cancer cases were attributable to NAFLD and just over 15% were attributable to alcohol-related liver disease. The robust data to inform the underlying etiologies are not always available, the burden is shifting in middle and high-income countries to non-viral causes. This means that prevention interventions around tobacco and alcohol control and promoting healthier lifestyles could also address liver cancer. Given the changing profile of liver cancer, it's important to communicate its prevention and control, even though this can be challenging. The focus for liver cancer control would be best placed on prevention, hepatitis screening and treatment, and early detection of liver cancer. Thus, it's important to integrate liver health and cancer risk messaging with viral hepatitis elimination plans and cancer prevention and control plans to raise awareness in both the general community and the clinical community. The focus could be on finding synergies to support earlier testing and treatment for hepatitis. Where this is already done, hepatitis control efforts need to be reinforced to ensure coverage for all population groups. Progress has been made, and we should continue to engage in conversations about liver cancer and the complex interactions with hepatitis and other risk factors to reduce the future burden. Thank you.
Thank you. Thank you very much for this excellent presentation and showing the importance of viral hepatitis in the risk of development liver cancer. The next presentation will be made by Marco Korenjak. And Marco is the president of the European Liver Patients Association, and he's going to talk on how a white paper on liver cancer can contribute to hepatitis elimination. Welcome, Marco.
Thank you very much for excellent introduction. And prior to starting my presentation, I would like first to congratulate the World Hepatitis Alliance for organizing, again, excellent event. And big congrats also to Professor Buti and Professor Gamal Jiha, and kind regards to Geneva. So I have two parts of the presentation. So the first part presentation is mainly about who we are and what are we doing in order to receive information about how to structure a patient movement that could really make a difference. But because I agreed with the organizer that I can send you the slides, I will save some time into just going into the white paper, why the white paper was produced, and what are we doing with that white paper in regards of hepatitis elimination. So we are fighting for people who have liver diseases in Europe, WHO European region, and we want to try to make that everybody gets treated in time. And we follow several values that are connecting our members. And in regards of that, we are following also some of the strategic goals. Here you can see all the members of European Liver Patient Association. We have members, 31 members from 25 countries in Europe, and we can really see what is happening with hepatitis B and C, viral hepatitis in Europe, how the elimination is going, or rather how it's not going. In regards to the structure, every association that wants to be part of ELPA needs to prove that the management board of the association is made of patients, of patient relatives, and at least 50% of them is managed by patients. We have several different working groups. We have a working group of hepatitis elimination, and of course also a working group of primary liver cancer that works under Dr. Teresa Casanovas and was the one responsible for production of this white paper. The research took 1.5 years and was led by a professor, and we interviewed patient groups, we interviewed some of the medical experts to produce a paper that we can use as a leverage point for decision makers at the highest European institutions. In regards of our collaboration with medical field, we are currently in 10 medical research projects that are financed by European Commission, and here are all the logos. In regards of the white paper, so of course, if you have seen in previous presentations, we all have one in common, and that is elimination of hepatitis. Regardless of if you are looking at global south, global north, we need to eliminate hepatitis in order to produce positive effects for our members, for our patients. The purpose of the white paper was also to assist the health policy makers across of Europe, WHO European region, to identify the key priority areas in the unmet needs with the view to implement the best practices for liver cancer patients based on the currently available evidence. This paper was presented at an online event because of COVID crisis and was also supported by John Ryan, who is now the director of Europe of this DG Health at the European Commission. So we have few recommendations. For example, if we look at prevention, we need to focus on viral hepatitis. If we are able to lower the viral hepatitis cases with specific screening and then action into treating people, we will also lower the number of cases of liver cancer in Europe and worldwide. We need to scale up screening. As you know, we have been under the influence of COVID crisis, which has made screening programs across Europe and across the world unavailable because we tried to tackle the COVID. But now we think it's a great start to restart this action again and try to restart the screening programs. And we need to screen the people that are in the risk groups in order to find the viral hepatitis that we have not yet detected. Of course, in regards of the optimization of patient involvement and empowerment, in regards of health literacy, I don't know how is your feeling, but I do feel that with the COVID crisis, we had gained some very positive influence on knowledge about health issues. I have friends, family members who are asking me about health issues, and I think we need to leverage that and try to bring this into the next phases where COVID will not be there, but health literacy about things that are important will be there. So of course, we want to promote and we need more patient involvement in the research, not just at the end of the process, but from the beginning. For example, from the start of when doctors are trying to make up a clinical trial research, we need to be there and try to provide opinions about what is feasible and what is not. One of the greatest things that we achieved together with World Hepatitis Alliance, with EASL, with other partners, was the changing of the text of the European Beating Cancer Plan, which now includes also elimination of hepatitis B and hepatitis C as one of the primary points for prevention of liver cancer. And if you have any questions, do not hesitate to reach out. We will make sure that also the slides are available for you. And thank you very much for your attention.
Thank you, Marco, for this excellent presentation. And we move to the next speaker, Wan Long Chong. He will talk about changing viral etiology of hepatocellular carcinoma. Please.
Good afternoon, Mr. Chairpersons, dear colleagues. I will talk about changing viral etiology of hepatocellular carcinoma in Taiwan. Taiwan is hyper-endemic for HPV and HCV infection. The prevalence of HBsAg is about 15 to 20% in adults. The overall anti-HCV positive rate in adults is 4.4% in Taiwan. 1/3 of the patients with chronic HPV infection will proceed to chronic hepatitis. 15 to 40% of patients with chronic hepatitis B will develop liver cirrhosis or hepatocellular carcinoma. 60 to 80% of the acute hepatitis C infected patients will become chronic hepatitis. 20% of chronic hepatitis C will lead to liver cirrhosis in 20 years. In cirrhotic patients, the annual rates to develop hepatocellular carcinoma are around 2 to 7%. Therefore, HCC becomes one of the major health problems in Taiwan. For the primary prevention of HPV-related HCC, HPV vaccination and raising the awareness of people are necessary. Taiwan government started the mass hepatitis B vaccination program since 1984. Infants born to HBsAg positive women were given a hepatitis B vaccine, and all the newborn received HPV vaccination after 1986. The coverage rate of HPV vaccination increased to 98% in 2018. The prevalence of HBsAg declined from 9.8% to 0.4% in 35 years after hepatitis B vaccination program. There was a continuous decline in HCC mortality rate and incidence for both cohorts long after implementation of the HPV vaccination program. The mortality rate of HCC decreased 90% and the HCC incidence decreased 80%. Because of lacking effective vaccine so far, Taiwan government adopted the policy of treatment as prevention to prevent the occurrence of HCV-related HCC. The Taiwan Health Insurance reimbursed the treatment of chronic HCV infection since 2003. PEG interferon and NUCs were used for treating the patient with chronic hepatitis B and HBV-related liver cirrhosis as the secondary prevention for HBV-related HCC. Taiwan Health Insurance also reimbursed the treatment of chronic HBV infection since 2003. Both the pegylated interferon and NUCs are reimbursed as a first-line therapy. The result from a multi-center clinical trial in Taiwan demonstrated that interferon-based therapy decreased the occurrence of HCC in chronic hepatitis B patients, especially in patients with liver cirrhosis. The retrospective nationwide cohort study demonstrated that NUC treatment was associated with low incidence of HCC development in patients with chronic hepatitis B. Interferon, ribavirin, and DAA were used for treating chronic hepatitis C patients and HCV-related liver cirrhosis as the secondary prevention for HCV-related HCC. Initially, pegylated interferon and ribavirin combination therapy was used as a first-line therapy. Treatment with oral DAA were reimbursed since 2017. Sustained virologic response by interferon-based therapy could reduce the risk of HCC development. The cumulative incidence of HCC decreased from 35% in untreated patients to 3% in patients with an SVR. Treating underlying viral infection in patients with HPV and HCV-related HCC could be applied as a tertiary prevention for HCC. Data analysis based on the Taiwan Health Insurance Research Database shows that post-operative NUC treatment was associated with reduced recurrence of HPV-related HCC. The data analysis from the Health Insurance Research Database also demonstrated that the post-operative PEG interferon and ribavirin treatment was associated with reduced recurrence of HCV-related HCC. The HPV accounted for 80 to 85% in the causes of HCC in Taiwan, while HCV infection was found in 10 to 20% of HCC patients in 1990s. The prevalence of HBsAg and anti-HCV in HCC patients changed to 50 to 60% and 35 to 45% respectively in 2015. To prevent HCC occurrence, Taiwan government conducted mass hepatitis B vaccination program since 1984, launched universal health care in 1995 and reimbursed viral hepatitis therapy since 2003. During the past 40 years, the overall HCC mortality and overall HCC incidence peaked at 2010, then declined. The overall HCC case fatality rate consistently declined through the entire period, and the estimated prevalence of HBsAg and anti-HCV in HCC patients were about 50 and 50% after 2010. In summary, dear colleagues, Taiwan is hyper-endemic for both HBV and HCV infection. Because HBV and HCV infection could lead to HCC, HCC is one of the major health problems in Taiwan. To prevent HCC occurrence, Taiwan government conducted mass hepatitis B vaccination program since 1984, launched universal health care in 1995, and reimbursed viral hepatitis therapy since 2003. The prevalence of HBsAg decreased approximately to 50%, and the prevalence of anti-HCV was about 40 to 50% in HCC patients after 2010. Taiwan government aims to eliminate the HCV infection before 2025. Therefore, the incidence and mortality of HCC will be further decreased in the near future. Thank you for your attention.
Thank you for the excellent presentation and showing the important role of vaccination and treatment for prevention and reducing the risk of liver cancer. So I would like to ask my co-chair, Professor Gamal Shisha. We have, I think, time for very short questions. Gamal, if you like to share
Yes. First, I want to thank all the speakers for their excellent presentations. And now we have time for questions and any comments from the participants. I will start with a question, a burning question to Lewis Roberts. Yes, would we reduce liver cancer, Robert? Liver cancer deaths everywhere, not in sub-Saharan Africa, if we treat people at a lower viral load?
That is a wonderful question, and thanks for asking it. I think that much of the data upon which we base the decision of what viral load to use in treating patients was derived from countries in Asia, where we know that either a combination of the host and or the viral genotypes that we see is that we see fairly high levels of the virus persisting into adulthood. And I think one of the challenges is that more recently, we are getting information on hepatitis B virus integrations and the effect of early treatment on the levels of integrations that suggests that early treatment may reduce the level of viral integration. And so it may be that it would be best actually to treat everyone earlier. But our challenge is developing an evidence base for that. And I think that that's one of the most urgent needs, is to develop that evidence base globally.
Is there any data that supports this at present?
I think the data that supports it is from studies of looking at viral integration. We know that a proportion of individuals who get hepatitis B-induced cancer will get cancer in the absence of cirrhosis, where it's promoted by viral integration. And we know that those individuals that receive treatment with nucleosides or nucleotides have decreased rates now of viral integration. That's been shown. The other evidence that I think is important to develop is from the HIV treatment programs. Those with co-infection of HIV and HBV are treated with regimens that typically include tenofovir to suppress the HBV viral load at the same time that the HIV is treated. In some cohorts that have been studied, there have been very low rates of HCC development in those individuals who are treated with tenofovir-based regimens when they have co-infection. But we need more information about this, particularly from regions such as Sub-Saharan Africa, where what we hear from the programs there is that they often don't have sufficient follow-up of patients to know for sure whether the incidence rates of liver cancer have decreased.
Thank you, and we may need to hear the experience of Professor Bhuti about this. Can we treat at a lower viral load?
Currently in my country, we only treat very selected patients with low viral load, to be honest. But what I think is really important in sub-Saharan Africa is to increase the vaccination and have vaccination programs like Taiwan. So for me, I think this is a key point. Probably it takes some time to see the results, but I think it's really, really important because there are still very low rates of vaccination in some of these countries. And the example of Taiwan, starting with vaccination and moving to treatment for both, for hepatitis B and C, it's really, really impressive. I have a question to Luciana and also to Marco. I think patients associations play an important role to fight viral hepatitis, and they are very focused on viral hepatitis and less focused on liver cancer. How to move or how to increase awareness on liver cancer? I think we are running short of time, but perhaps a short comment on how to stimulate patients to help us fighting liver cancer.
Cancer, Maria. In our experience, we are a cancer NGO, so we are trying a lot to get to the involvement of the liver cancer patient. So it is not easy because he's not so involved in the cause. I think now it's changing a little bit because he's alive. So this is so important. And we are also using the force of the caregiver to help us to have strong testimonials and to really talk more about the liver cancer.
There is a question to Professor Juan about Delta hepatitis in your country. How much is prevalent and what is the treatment you are giving now? And what is the relation to liver cancer? Dr. Juan Longshong?
Yes.
Yes. Did you hear the question?
Yes, I understand.
Okay.
The prevalence of Delta infection in Taiwan is about 2 to 3%. But now we have no any effective drug to treat Delta hepatitis. So initially we can treat with PEG interferon, but now the interferon is not used. So we are waiting for the Microdex to our country. So I think in 2 years or this years, we can have new drug to treat the Delta patient.
What's the prevalence
The
of
prevalence
Delta
is
in your cohort?
yes, in our cohort is about 2 to 3% in Hep B patient, only 2 to 3%.
Thank you very much, and thanks to all the speakers. You have a question? Huh? Last question, please.
Okay, thank you.
Open the.
Yes. Congratulations to all speakers. Thank you for the presentation.
Please identify yourself.
I'm Casimir Manzengo from WHO Hepatitis Focal Point for Afro region, and I'm pleased to see many colleagues here. First thing about Taiwan, I'm pleased to hear that you are now running to the elimination of HCV in 2025. I think that it is an opportunity to make a good planning, strategic planning, using now the tools we have on elimination validation guidance. We have now a tools, so you can you can consider the main indicators we can follow during in yearly based. Every year to see what are the progress until 2025. And for Professor Lewis, thank you for the 3 questions. I think that those are the questions very important because it will help us, I think, over time to go to the simplification of the management case in the field. You know, in Africa, it's not easy to have the specialist at the peripheral level. So if we can, but we should have enough evidence. But if it is, I think that it can be a good thing for every people and for the universal health coverage. And lastly, for Mr. Gay, it is a very impressive testimony to see what are the issues for the health to access to a good treatment. And I think that your testimony can be used widely for like an argument to develop the strategy, the concrete strategies for the universal health coverage for hepatitis patients. Because I can understand that you begin by the peripheral level, but no action, no diagnostic, and it takes long time to understand that the problem can be.
We all learned from Ibrahim's story, and a final word from Dr. Hassani from Egypt.
Thank you very much, Professor Gamer, for moderating the session with Professor Maria Bouti. I just have one comment on the presentation of Dr. Lewis regarding the survival. Thank you for putting some highlights about the difference in survival rates of HCC patients between Egypt, which is 11 months as you present, and different countries. And I would like to that the Ministry of Health and Population endorsed a program for surveillance of HCC in different Egyptian governorates for those who discovered to have liver cirrhosis. Came out from the mass screening campaign, which is almost 250,000 patients. And not only this, but also the adoption of different lines of systemic therapy, starting from the first line to the second line therapies, which will for sure reflect very soon on the survival rates of HCC patients in Egypt. Thank you very much.
Thank you very much, Dr. Hassani. And again, thanks to all the speakers, all the participants for this excellent session. And finally, before we end, there is a poll on the platform. Please click on the poll and provide your insight so it can help. Thank you very much. Thank you very much.
Thank you very much.
Thank you. Thank you a lot.
Thanks, everyone.
Thank you. Thank you. We will need a lot of discussion, Robert. A lengthy discussion. Ibrahim.
Professor, thank you for your help.
Thank you. Thank you.
Thanks.
Thank you.
Thank you.
Thanks, Maria. Thanks very much, Maria.
Thanks.